Welcome to our webinar on medical decision making, one of the most valuable life skills you can have as a patient in today's American medical environment. I'm Ed Morgan, founder, and before we introduce today's guests, just a word about our Medical Wisdom Project itself. We were founded in 2021 to provide thoughtful people with the tools to navigate today's medical maze and get the best care. We provide unbiased knowledge of what's going on in American medicine, what to use, and what to avoid. We teach you how to make the best decisions in your doctor's office as well. And that's today's topic, medical decision making. We're honored to have with us Dr. Robert McNutt, a physician with decades of experience who has served on the faculty of 2 medical schools and is currently on the faculty of a business school, teaching MBA students how to use these same decision-making principles to have a successful life. So Bob, welcome.
Thank you very much. It's my pleasure.
So I'll interview Bob first, and then we'll be pleased to take your questions. Bob, your passion as a patient advocate is to help people make the right choices, the wise choices in medical situations, whether it's a simple recommendation to take statins or treatment options for stage 2 cancer, or anything from simple to complex. So Bob, why is medical decision-making so important today?
Well, medical decision-making has been important prior to this environment. It's been important for forever. I really appreciate the listeners. I think we should set a couple ground rules here about what we're talking as I think about this. The decisions that we're going to be talking about, Ed, from my perspective, which puts the patient at the center of the expertise of the choice, are not the acute urgent care decisions that occur in an intensive care unit or an emergency room where you've got to act quickly to save a life. I've been a first responder at several car accidents, and I've had to place like chest tubes to save people's life right in the middle of the accident. I didn't ask them. I didn't ask for their choices. You just do things to save lives. What we're going to talk about today is where the patient really gets involved, is in those decisions where you have time to make a determination about which options might be best for you. Because every single decision that you make in a chronic setting or in a long-term setting is going to come with a trade-off. There's some better things for you for some options, and there's some worse things for you, and it's never better all for every aspect of your care. So you're going to have to make some trade-offs, and only a person can make those trade-offs, because those trade-offs involve values to you as a person, how you feel about the outcomes of care, how much risk you want to take, how you would balance some good potential outcomes against the risk of some bad outcomes. That's what makes the person the expert. Now, clearly patients aren't going to know the anatomy and the physiology, but that's not the expertise that comes to bear when you're making a decision, Ed. What comes to bear when you're making the decision is how an individual feels about the benefits and harms of the potential options for their care. And nobody can determine that except the person. So I'm a firm believer that individual choice is the basis of high quality decision making.
Well, thanks for that. I thought as I learned about this process myself, I was surprised to learn that both parties seem to come to the process of medical decision making with biases, and maybe it would be good to identify what some of those might be. In other words, we think we're unbiased observers, but actually we bring our own prejudices, both parties, to a decision.
Well, that's for sure. And in fact, I just baked some lemon poppy seed muffins, and I followed a recipe, and they turned out pretty well. And so hopefully over the time you and I spend together, and the listeners, we're going to develop a recipe for good decision making. And one of the detriments to a good recipe is not believing that you can make your own choice. And I think just before we were starting, I was telling you, I just had a phone call today, and I'm going to be talking to the patient this afternoon, an 84-year-old man who serendipitously is determined and found to have prostate cancer, is scheduled for a very aggressive surgery. And despite the fact that his family and his primary care doctor say, no, you don't need this surgery, there's no benefit, he says, look, that guy's an expert. That's the urologist. He found it. How can I tell him, no, I'm not going to have my surgery? That's a bias. That bias for listening to an expert is a common bias. The other common bias, I think, that precludes people becoming involved in their choices is fear. I see that every day, right? How do you get rid of it? You've got to put it aside. It's clearly something we all have, but we have to put it aside at the point of time we have to decide, because it can fool you, and it can make you misinterpret the values of some of the treatments that we are given. Those are very ones. I mean, the other one is rush to judgment. I mean,
Yes.
here's an 84-year-old man who's, the doctor told him he needed this prostatectomy. He's talked to him not about the prostatectomy, but the robotic, how much the robotic experiences he had doing the surgery, which is totally irrelevant to the person's choice. But that's how they spent their time. And they set up the surgery for 2 weeks with no time to discuss it, nothing. The rush to judgment, the rush to the treatment is a bias. And if all the listeners take nothing away from this our conversation, is you've got time. You got time to make these decisions, right? One of the options for this man's care is to do nothing. He might live another 10 years and never have any effective prostate cancer whatsoever. And even at his age, if he's got prostate cancer, he's almost got a 20-fold risk of dying of something else other than the prostate cancer. He's got to take time to come to the sense that he can make this choice. He can weigh the trade-offs, and spend some time making a decision from his perspective. And so that's a very important bias that happens all the time.
Yeah. And how about conflicts of interest? I mean, on the medical side, a doctor may want to give us his best judgment, what he would do with his grandmother, right? But he might have some conflicts of interest in some way.
I always said, would I go to a stockbroker to ask whether or not I should invest in stocks? No, I wouldn't. I mean, would I go to a urologist who's doing surgery to decide whether he should have surgery? No, that's just not smart. And yet there's a sense of expertise in the public that they're the ones that know. And that's the point I'm trying to get at. They know urology, they know medicine, they know about the heart, they know the liver, they know the anatomy, they know the physiology, but they have no idea how to make a decision. They can't make a decision any better for you than nobody can make one for you, because patients are the ones that either reap the benefits or suffer the consequences of the choices they make. Not me. I'm an oncologist, Dad, right? I ask people to take chemotherapy all the time. But I'm not the one who suffered from the chemotherapy. So I always involve the patients into, okay, if you take the chemotherapy versus another alternative, here's how much better chance you have of living a certain time or having a better quality of life. And here's the number. It may be very small, but here's the consequences. You might have to suffer some very serious consequences of the chemotherapy. This was especially pertinent because I was a pediatric oncologist, and I would see kids with leukemia, for instance, right? And I would offer them chemotherapy, and that chemotherapy would have a chance of maybe giving them a long life and maybe even a full life. In fact, I still get Christmas cards from some of the acute kids with acute leukemia. But at the same time, they have a risk. They had about a 10% chance of dying of the therapy. So there is my conflict of interest. My idea about what might work for you is a conflict of interest. And whether that is motivated by some factor other than than your well-being. It could be money. I mean, a urologist has a hard time saying no to a prostatectomy because of what it brings to them. They shouldn't be in the decision frame at all. No technology person should be in the decision. It's not part of the algorithm for making a choice, believe it or not. The choice is made by the person who is informed of the best decisions. So conflict of interest is a real problem. There's all kinds of other conflicts of interest, right? Avoiding legal complaints. Doctors talk about it. Surveys of doctors, patients should know this, that surveys of doctors found that over 90% of physicians will say that they'll alter their decision frames or their suggestions to patients for fear of litigation. So all those factors lead to one very simple conclusion, and that is you got to make your own choices, and you got to learn how to do it. And I think that we've been remiss in the profession of medicine. Fortunately, became more of a business, but in the profession of medicine, we were remiss in not doing a good enough job of teaching and allowing patients to be part of the decision process, from my perspective. And that's what I'm really proud of your Wisdom Project. I'm proud of the people are on here. It's how I spend my day now. I don't give people decisions. I tell them what the consequences of those choices might be, and I help them wrestle with those consequences. And that's exactly the way medicine should proceed.
Wow. Yeah. And so with the students that you're now working with, I mean, where do you start on this complicated process of turning yes people into smart people or non-naive? That's a process.
Yeah, it's interesting. I'm looking at your picture and I'm looking at my picture, and we're probably in the baby boomer generation, I would guess.
Yeah, we both are.
And surveys of baby boomers show that they like their doctors, and
Yes,
um,
I like mine. That's true.
they do. And yet when I ask my 25-year-olds and 35-year-olds and stuff like that, they go, "I can't stand those people. They're only out for themselves." But then they go off on some other tangent and go get some foo-foo vitamin or something. They've got to get, even though they may not be as trusting as you and I are, they still don't know how to make a choice. So it has always been, I'm glad you asked the question. This is how crazy I've been about it. I think medical decision making and the process and if you will, the bakery recipe for decision making in medical care fits almost every domain. Law, I take legal cases and I apply medical decision making or decision making concepts to those. Business is ripe for improvements in how we go about getting data and making decisions. And to that end, I've always thought, I think these skills should be taught in high school. And that's my dream, to go back and be a high school teacher teaching this process. And that has been difficult because every time I would approach a medical institution to say, I'm going to teach decision making to non-physicians and non-nurses. I want to teach them to the public. They tell me to go jump in the lake.
Right.
And, by a series of fortunes, good luck, I'm now teaching it in medical school to undergraduates. In business school. And it has been a remarkable experience. I think I told you the other day, I had a patient come into the room with a question about whether or not they should be scanned with a CT scan for lung cancer. That was their question.
That's a good one. Okay.
And I said, well, what I'll do is I will go in front of the class and that patient and I will have a conversation. And I'll go through the way I talk about it. I talk about bias. Where are you in a bias? Where are you in the clinical situation? What options do you might have? How much benefit will there be? How much overdoing nothing would there be? How much harm would there be because there's a false positive rate? You may get biopsied. I'd go through the whole process and help them make the decision, right? That makes sense. That I'm presaging a little bit of the recipe, I guess. A little tricky on my part. But um, I decided on the way to the class, no, I'm not going to do it. So I chose a student out of the class 3 months into this class.
That's risky. Okay.
It was risky. And but I wasn't stupid about it. I knew that there was students I had in that room that even though they might know the process,
Right.
they would start drooling all over themselves or babbling. I mean, they just couldn't handle the stress. You know, you get to know your students pretty well, but I know there was some students in there that would actually relish the opportunity. So I chose one of those. I told him it was random. I lied. It wasn't random. I picked his name was Luke. Is incredible. He missed for the first 2 months of the class. He didn't get a single question correct on any of our quizzes. He was flunking. He didn't get a single question. And all of a sudden, one day he said, "I get this." And he just blossomed and he got down to it. He started learning to find the information and using it. So I had him interview the patient. And I'm sorry I didn't videotape it. I almost cried. He went through the entire process. The patient said, "Oh my goodness, I didn't understand all this." He went through the numbers. He went through the consequences. He went through the risks. He went through the whole process. And he would ask the students in the class to go get him data. And they were on their phones. I told them how to showed them how to get the best medical data and how to get the best data from searching in any domain. Part of it is how do you find good information, and we could talk about that.
Let's talk about that next.
Okay, but I want to finish it.
No, finish your story. That's
You
good.
wouldn't believe that the guy went up out of there. He says, "You've helped me so much. There's no way I'm getting the CT scanner. My doctor's out of their mind because there's no benefit whatsoever. There's no benefit to life expectancy. There's a 7 to 10% of the people end up with a biopsy of their lung without even having cancer. And the test even misses about 20% of the cancers even is there." So he saw those numbers and he went, "Whoa, I'm done." And he gave that student a standing ovation. This is a undergraduate business student, right?
Wow.
So
Wow.
I know it can be done. And
Yes.
I know the public can learn it. We just got to start it early.
So,
I've done this. I piloted it in high school, and those kids are smart
yeah.
and they're unbiased, and they
That,
don't come with all the baggage.
so
And
that's amazing.
I think
So,
your medical wisdom project, and I'm going to move this class into a bigger, broader spectrum next year. We're going to try it on all incoming freshmen. And we're going to get a sea change in the practice of medicine if we have informed public that knows how to use the information. Then they won't be so beholden to expertise other than their own.
so you're saying, Bob, that the raw material for decision making is either readily available or available to smart people, or you can figure out how to get there. Um,
Every person has the ability to get there. I mean, it was funny. I was in practice for 10 years as a private doc. So I was taking care of cancer patients. And I saw the world changing. This thing came out called a computer. And
hmm,
yeah, believe it or not, at that, I mean, we had paper and pencil. I know I don't look that old, but the computers came out during my time. And I was blessed because the National Institute of Health gave me, because I was so busy, it gave me a computer on my desk with a telephone line to the National Library of Medicine, where there was a database of every single article on cancer. It's a remarkable data set. I saw it and I said, why did I have to train in oncology? I mean, it's all here. So that told me that the world is changing dramatically. So that made me go back to school. So I went back to school when I was 40 years old as a National Library Medicine Fellow to learn how to do decision making, to study decision theory, to figure out how to move it so to the patient. Then I became involved in actually with a group of people setting up PubMed so we could search it. I wanted to be a public Medline, but it's publisher's Medline. And I, as a journal editor, I pushed for a long time to have a patient page that actually gave patients data so that they could learn to use it and do it. But I failed in that at JAMA. It was a patient JAMA. I was going to call it pajama, but the editor wouldn't go for it. but they, now with
That's
Google,
cool.
Google is a search engine, Chat GBT is a search engine, Bard. You can now use terms like PubMed.gov to any search you use, and it'll immediately get you to the National Library of Medicine database of high quality evidence for medical decision making. So that's what I taught my students to do. And so right in the middle of the class, they were looking up data and giving it to the patient and Luke, who was talking to him in real time. And there's an important aspect here. Science, clinical science, revolves around the randomized controlled trial. Now, we need to talk about that a little bit. Perhaps, maybe if if
Sure.
you're going off in a direction you don't want me to go, Ed, you're the boss. But
No, let's take a couple minutes. That's great.
a lot of medical evidence comes from very poor study designs. Let me presage this. Give an example. There is a study out there run by the National Institute of Health with almost 500,000 women in it. They follow them every year, year in, year out, year in, and they ask them questions. And they've been following them for years, I think over 20 years. And every year they ask them questions. How are you sleeping? What are you eating? Are you married? Do you have a dog? Do you eat vitamins? Do you exercise? They ask question after question after question. And over time, things start happening to people, right? They start having a heart attack. They start getting cancer. They get diabetes. They have kidney disease. And all of a sudden, they start trying to draw a relationship from some of these questions they asked and the outcomes they are seeing. Does that am I being clear here, Ed? Am I making
Yeah, no, that's totally.
and so, and all of a sudden they'll say, well, by golly, if women are taking estrogens, I'll give you one example. The women that are taking estrogens seem to have a lower risk of heart disease. And everybody goes, oh, that's cool. Let's write it up. Let's put it in a medical journal. I think it even went into my journal. And all of a sudden, estrogens were given to over 70% of women who were having menopause. And then somewhere along the line says, that's observational data. That's unplanned comparison. Nobody told what woman or which women would get the estrogen. So that's not really science. That's just following what people do. People choose on their own. And so you have to be real careful because there may be other factors that be confounding it. So when we finally did a randomized trial saying, well, we're going to give estrogens or not, that we shut the trial down? I think it was supposed to plan for 5 years. This trial was shut down in 2.5 years because estrogens were harmful. They were causing heart disease. They weren't helping it. We see this all the time. We see certain surgical procedures for breast cancer that went on by theory and observational trials that when tested in randomized trials, where you can balance the factors that matter to people so you can independently find out what works better or not. We finally found that those things that we believe worked didn't. So when I talk to patients, Ed, I only use randomized controlled trials. And if you only look for randomized controlled trials on the National Library of Medicine, you can get the best data within milliseconds.
Yeah.
I will find data for patients within 2 minutes amongst every complex medical issue there is. Now, I know that's not maybe easy for everybody. That's why, I started my website and you're doing your medical. I think that's one thing that the Medical Wisdom Project should have a little link where people can go to find out what are the benefits and what are the harms if I go through this and what are the. I think that's coming. I think that's the future. I think people will have access to that easily. So I think that's help. I hope that's helpful, and I hope people realize, if a doctor asks you to do something, you say, well, tell me what the randomized trial results are, and what you'll find is they'll start scratching their head and go, well, I guess I have to look it up. But that's a good place. You got to stop the doc and make them tell you what's going on.
Yeah.
So, there's a part of this process of decision making is going to be, how do we get people the courage of their convictions to step up once they know how to do it? That's just a long-term goal and a long-term need, and we just keep working at it. But I can tell you right now, if my first cohort of high school students that come out doing medical decision making is going to change how they interact with their physicians.
That's
And
wonderful.
that's exactly what
Right.
we need. That's what we need.
So can we talk a little marketing? I mean, as long as we're looking at studies and how data can be manipulated, um, could we talk a little absolute versus relative risk? And could you elucidate that principle for us a little bit? Because, results are not always what they seem.
Uh,
And
that's a really great question. I'm really glad you brought it up because if there's a core message, the one was take your time to make choice, understand the added benefit, the added risk. Those are really core principles. Another core principle is you got to understand the numbers. And the only numbers that matter is absolute differences. Okay. So I could have a 50% reduction in something. And that mean I went from 0.5% down to 0.25%. So relative numbers are very biasing. You talked about bias. One of the most biasing things we do in marketing and presenting information to patients, we use relative numbers, right? There's a 62% improvement in your symptoms of depression if you take X, Y, and Z, and you bear down on it, and it's about 1 percentage point, right?
Mhm.
We heard, for instance, to give you an idea, we have the shingles vaccine. So they say, well, my gosh, you take a shingles vaccine, well, 90% reduction in your chance of getting shingles. Well, that was from 0.8% down to about 0.1% chance. The absolute difference was very small. The relative numbers are big, right?
Yes.
I actually, I'm sorry.
No, I was just going to say my favorite is the AFib advertising on television, right? So you're 5 times as likely to have a stroke if you have AFib, right?
Yeah, there was a time during the COVID experience that the CDC said if you're not vaccinated, you have a 5 times the chance of dying. And that was a fascinating, I've got the data, I showed it to the students. They cherry picked a certain period of time. There was no difference from the time for a few months before it, and there was no difference for the few months after it. But they called it at that point in time, and it was 5 times larger if you were unvaccinated, which meant a difference between 1 in 100,000 and 5 in 100,000.
Yeah,
So
that's relative risk.
relative risk is dangerous.
Yes.
I actually tried to pass a bill in Illinois. I wrote a bill um, in Illinois saying that it's wrong, it's unethical to present relative numbers to the public. And I wanted Illinois to stop it. I mean, there's only 2 countries that allow direct to consumer advertising.
Yes,
All
sir.
the world. There's only 2.
Yes.
Brilliant countries. They're wonderful countries, but they don't always do smart things. One of them is the United States, and the other one's Australia. And the numbers that are presented to the patient, I did this research myself, it's all relative numbers. 30% reduction, 40% reduction, 50, 60, 90% reduction.
So,
Nobody's
so
presenting the absolute numbers, which are minuscule.
yeah. So, Bob, most of our listeners are probably bombarded with television ads, if they watch any cable or any network at all, right? Dinner hour, symptoms, and all this. And would you say that most of the information, the statistics that are used there are relative risks?
Oh, yeah. I don't know what it is anymore, but we studied it one time. It was virtually 100%.
Yeah.
I've yet to see an ad that gave it an absolute difference.
Yeah.
It flabbergasts me, but there's a reason for it because we know studies have been done. We've done randomized trials where we gave people information as relative data and as absolute data, and there was a marked difference in what people would accept for treatment.
Yeah.
And as you imagine, a relative decline of 50% sounds big, and they would take it. But when I told them that's only 0.2%, they wouldn't. So a real great learning point for anybody that wants to be a participant in their care is to say, okay, doc, you say that's better, but how big is it? Okay, what percentage is it? Is it 100%? Is it 5%? Is it 2%? Is it 0.2%? Right? Like the death rate from lung cancer for doing a CT scan is in the 0.1 to 0.2% range over 6 to 10 years, not yearly. So those numbers look very different than the quote unquote reported 20% reduction in death from cancer. So people have to know this. This is a huge bias. I'm so glad you brought it up. If nobody else goes away from with that, you never, it's easy to say, don't look at those ads. I mean, I've always said that if there's a really good treatment out there, your doctor will know about it. You don't need an ad to tell you about it. And in fact, if they're giving you the ad, it's probably not worth a dang. And they're trying to monitor and push a look-alike or their specific drug, all those kinds of things. It's unfortunate, but it's true. Like it or not, that's why you have to be an informed consumer. You have to have a medical wisdom project.
Maybe just one more question, then we'll give our listeners a chance to come back at us.
Am I doing too much? Is it too much, too little? Give me.
I think our listeners are learning a lot. And so one of the questions I would ask you is, let's say your next doctor's appointment, let's say you become convinced of this and your mind has really been turned around today. I mean, how do you broach this subject with a man and a woman in a white coat, and you don't have a white coat? I mean, just how do you start, looking for conservative treatment? What would you say? Your doctor, I've got mine convinced. He says, I actually agree with you that we should pursue conservative options first, and we should carefully do everything but not everybody wants to actually do that. So I don't know.
Yeah, I'm a child of the 60s. My dad told me that my first word were why. For dad, but why?
Yeah.
I told my physician that if I saw a PSA test or a cholesterol test on my labs, that I would sue him. Because I don't want to spend money. I don't want my insurance to spend money. I don't want to waste anybody's money because I'm not going to do anything with those because I know they just not going to make a big difference in my life, right? So that's how aggressive I am. But anytime a physician, anybody says, I'm going to have you do this, you should say, as opposed to what and why. And what are you expecting me to get from a benefit perspective, and what's the potential risk of it? Tell me those numbers, and then we'll have a conversation. That's the way it should be. That's exactly what my students, I tell my students, this is what you're going to say. I made them, as their final exam, they had to come up with the answer to your question. What are you going to say the next time somebody offers you a choice? And I have 26 answers on the final exam that I can hardly wait to put in a book. Some of them are pretty comical. But I don't know if that's helpful. It's easier said than done. Look at this 84-year-old man. This man's a former professor that's going to call me this afternoon. He's a successful person. He started businesses. He's done all kinds of things. And when his doctor said he needed a prostatectomy, he said, thank you very much. That's a problem.
Yeah.
That gets you in a lot of trouble today.
It's tragic. Yeah. In my book, I recounted that about 60% of Americans over 55 have had some chronic disease diagnosis and are on 2 or 3 permanent or semi-permanent drugs. And that's not true.
It's part of medicine's problems too. I think the new diagnostic code book for medicine's got over 35,000 diagnoses. I can tell you there's not 35,000 diagnoses out there. Those are billing codes. there's very few diagnoses, right? Cancer, uh, infectious disease, inflammatory disease, trauma,
Autoimmune. Yeah.
autoimmune. There's really a limited set of actual causes, self-neglect, all those kinds of, there's a limited set of causes that we've somehow expanded into things that are billable. But I don't need to be, the reason this is occurring is because somebody other than the patient is making the choices. And that's why a patient who's
Right.
really wise is going to say, you know what, I don't really think I got, I don't think I got that. Let's look over the tests and let's figure out why and what this could be. And I still do a lot of consults for diagnoses. Diagnoses are still missed an awful lot, even in this day and age when we have all kinds of fancy tests. But overwhelmingly, the problem is with the decisions. And as I've told you before, whoever controls the decision controls what happens in medicine. And right now, that decision is not necessarily in the hands of the public. They don't believe they can do it. And it's your job and mine to convince them that they can.
Yeah. Well, my heart is that each of our folks who are members of the Medical Wisdom Project learn how to live out their full natural life without unnecessary medical interference and
I like what you
unnecessary.
just said, unnecessary. I don't want people to come around. There are things that really can help you.
Oh, totally.
There are really, right? Yeah, if you're having a heart attack, you better get a blood thinner. That saves about 1 in 10 people that you give it to, right? But I mean, you don't want to give up. You want to look for benefit. And
Yes.
as you know, I've written a bill along with other people that pays for benefit. So even if we do this right, and people get to the point, Ed, where they see it and they can actually use the information and get it, we'll find a better system of money. We'll find, people have asked me, what do I think about a national health insurance? And I said, come back to me after we figure out how we're going to make decisions in the first place. And then I'll tell you what kind of health system we need.
Yeah.
We need decision reform. We don't need healthcare reform.
Yeah. Isn't that right? Wow. Look, maybe we should see if any of our listeners put down any questions. Jennifer typed in any questions. This has been very illuminating. Thank you.
You're very welcome. Thanks for having me. And I look
Well,
forward.
you're not off the hook yet. Let's see what we got out there.
Yeah,
I think I hear my phone ringing. I see Jennifer there. I said,
we do have
she's a Canadian. I think I'm being called somewhere.
we do have a couple of questions from the audience, and two of them are kind of connected. I'm going to start with one and then we'll roll into the second. So the first is, how do you deal with peer pressure from your own family? So people saying like, why aren't you doing what your doctor's telling you to do?
Wow.
That's all. That's a great question, and it is a real question. And when I do consultations with patients, Ed and Jennifer, I have the family in the room because they have to be educated just like the patient does, right? So if a patient finally comes to the realization that maybe they want to change their decision making, they go home and they tell their significant other. They've come back to me and said, I'm sorry, I just got countermanded. So I try to bring them into the room when I do it. So that to me, a consultation is a family consultation. The other, on my obnoxious side, and maybe that's hard to believe, but I do have an obnoxious side, but I will tell my family member, I said, okay, well, then you take your prostate out with me, right? Why don't we both go down there, and while I'm having mine, we'll get a twofer. We'll go 2 for 1. I mean, you got to stand up to it somehow, right? But you love them, they love you, and they mean well, but they've been like everybody else, medicalized, and it does create unnecessary consternation and stress. That's why we need a universal education in making decisions. And we need the families in the room when we're making those decisions. I've had some remarkable experiences with the families who are in the room.
Yeah.
And if it gets toward end of life questions, then it gets tragic, right? When
it could be
families disagree.
tragic. Let me give you one example. I was sitting with a pastor and his wife. They were both African Americans, and he was heading off for his prostatectomy, and the wife was smart as a whip, and she says, "Tell me, doc," it says, how many people have been studied?" That's not a question you get from people very often. I said, "That's a great question. Do you realize there's only 750 people that ever been studied for this surgery recently enough so that we could draw some kind of conclusions?" He says, 750? She said, "That's not a lot of people." I said, "No, there's a lot more prostates out there than there are people that have been studied." And she kind of laughed. She says, "Well, how many of them were Black people?" And I said, "Well, not very many of them." And she said, "Okay, honey, we're leaving." She got up off the table and they left, and it was done. It was over. And to her, that was an important aspect of this care that she couldn't. And I tried to stop her. I said, I don't think you're making a good choice there. I don't have any sense that African American prostates are different than white prostates. Let's stop this. Let's go back to the table. But to her, it was enough. But I never got a chance to get whether they were gone. I never saw him again. He didn't have his surgery. So it's a complex thing when families get involved. And I'm glad the listener raised it. But it's just like you got to stand up sometimes to doc, you stand up to your family members. And the way to do that is to go through the process. What are my biases? What is precluding me from making the best decision? If I just remember, everything's a comparison. Decision making is a comparison. Okay, if I do this versus that, how much better off am I? How much more do I get for it? Do I get 1%? Do I get 20% chance? Do I get all those things are really important. And then what kind of risk do I have to take? Am I going to end up in the hospital? I just dealt with a lady who decided to have a bilateral mastectomy despite no evidence. I told her, all you're doing is facing risk. And sure enough, she was in the hospital for a long time with an infected and necrotic tissue. There's risk. And if there's no benefit, accepting that kind of risk doesn't make sense. So you can inform your family, right? The better you are at making this decision, you can teach your family. I hope I'm not too flippant with that, because I think it's an important question. It's a very important question. It's an insightful question, but it's a question that should not stop anyone from getting a good process in their mind about making their own choices.
So on that same topic, informing your family, the next question is related into this. So the listener said, I have a friend with cancer who's inundated with crazy ideas from well-meaning friends. And what's the best way to show empathy without being another crazy friend? So we're talking about, we want to stand up and inform people about making better decisions. But when you're being told about crazy treatments and you are now being told, hey, you need to question everything, it can come off very much like you are another crazy person with a different crazy idea. So what's the best way to broach that subject and show empathy throughout that process?
Well, I think the best way to show empathy is to be empathetic, but boy, that's another really good question. I lived through, have you ever heard of Laetrile? You probably never.
Yeah, no, Mexican cancer treatment.
It was an almond extract, if I remember. Don't quote me on it. My memory is that it's an almond extract. And all of a sudden it got popular. Jennifer, it got popular, and everybody wanted Laetrile. And if I wouldn't give them Laetrile, they weren't going to come to me. They called me the worst doctor in the history of mankind, and off they would go to get their Laetrile. I had a patient actually come in with an entire box of articles about the value of Laetrile. All testimonials, right? What was that movie about Andy Kaufman? There's a beautiful movie that was Andy Kaufman, the comedian who got cancer, Man in the Moon or something. I think Jim Carrey, it was I'm sorry, these pop cultures, but I think he won an Academy Award for it. It shows him going to Mexico to get one of these alternative therapies. And I just want to warn people, or I just make a statement. alternative therapies can be very dangerous. Let me give you an example. Because I was an oncologist, I took the brunt of the AIDS crisis. Even though when I was at the University of North Carolina on faculty of general medicine, not oncology, over half my patients had AIDS. The reason for that is because oncologists were used to the infections the people with AIDS were getting, and AIDS people would get cancer. And the AIDS movement became scary, and everybody started getting into alternative therapies, ginseng, everything else under the sun. For somehow, grapefruit juice got to be a big one. Well, what we found was that those alternative therapies blocked the absorption of the drugs that were actually beneficial. So I was finding people that were getting benefit of the therapy that suddenly got worse again because they had gone into alternative therapies. Overwhelmingly, alternative therapies are dangerous because they haven't been studied enough to know whether they're any benefit. So I'm kind of draconian in that one. You don't take anything alternative. Doesn't mean that the practice of medicine is great and there might not be something wonderful out there. Well, then prove it to me. That's what I would say. Okay, they say you should be taking calcium and vitamin D 14 times a day because this will build up your bones while you're getting your chemotherapy. Good. Show me the randomized trial of 14 times a day of calcium and vitamin D, whatever absurdity that they talk about, and then people won't be able to come up with it. And you tell them, thank you for your concern. I love you. Let's go out and have a glass of wine, and let's not talk about this anymore. I mean, we got to stand up to it. I don't mean to be facetious, but I want people to realize this is not a game. You either know or you don't. You don't know, don't do it. That's not a bad rule, right? Not a bad rule. And you're going to find out your doctors don't know.
Oh,
they're going to be basing it on those unplanned studies.
I was going to say, Bob, that's the rule in both alternative and conventional medicine, correct?
Thank you very much. Do you know that I've taught medical students for over 25 years? After I got back out of practice, I became an academic physician. And I have been asking doctors every day on rounds. I would tell them, if you can prove me wrong, I'll buy you dinner at the best restaurant in stinking town. Well, that was Chapel Hill. There wasn't that many good restaurants at that time. So it was not a big deal. But I said, and I would ask them numbers. I said, you just put a Foley in that person. I said, what was the benefit of that Foley in the person? They said, well, I don't really know. The nurse told me to put the Foley in. And I said, well, then why don't you put the Foley in the nurse? If you can't tell me what the benefit of that thing was, why did you do it? And I've been trying to do that. Do you know, in 25 years, I don't think I've ever heard a doctor give me the right number.
Can I jump in here? One thing that we haven't talked today about is runaway hospital treatment, and perhaps that'll be we can do that on a follow-up thing. And because yeah. Okay.
Well, so before we jump into that, kind of on the same
Not
topic.
for today.
Yeah, is so that asking questions and challenging the presumptions of the medical system is not conventional. And so sometimes wise decision making can sound like a crazy alternative medicine, right? Because we are saying, hey, you need to think about it differently. You need to challenge what's being said. How do you inform people who are experiencing medical challenges about wise decision making without sounding like you're just a different alternative medicine?
Well, I will tell you what I told my students. I said, no, these are young students, right? They don't have to deal with a lot of medical care issues. And the way I got around that is I made them advisors for their family or their grandparents' choices, right? And so what I advise them to do is that if you're in the decision making, somebody says, I'm going to offer you a MRI of your brain to make sure you don't have a tumor. You say, well, thank you very much. Now, what's the chance that the MRI will find it if it's there? And could it find something that is not there? Can you give me the evidence, the numbers that'll show me how much better it is or how much worse it is, and help me think that through? And then they will hopefully do that, right? And they'll talk about it. And then I say, you know what? I think I'm going to have to go home to think about this, right? Because sometimes confronting them right at that point in time, I've had patients do it. I mean, I have some militant patients who have, that have learned this process and go right after their docs and have gotten into some tough situations with the docs, gotten fired by the docs. People are people that, it's not an easy process. So what I tell everybody is get the information and go away to decide. You don't have to decide in that room. You just got to gather information in that room, and you got to ask for clarification. You don't necessarily have to confront even when you ultimately confront, because if you go away and decide 4 days later and say, you know what, thank you very much. You really gave me the good information, and I've thought about it with my family, and we've decided we're not going that way at this point in time. But I do appreciate that you supplied that information for us. You can have some very good outcomes. Right? As recalcitrant as I am not in the context of making a choice with people. They have to have time, and you can step away from a situation without it being confrontational. I hope that's helpful.
Yeah.
I think that's common sense, but that's, I think, the way people should think about it.
Yeah, that is really great. I just have one last question here for you, and it's really about the regulating agencies that cover healthcare. And so you talked a lot about studies being really based on correlation and just observation versus actual randomized trials. And clearly we need correlation in order to create new hypotheses to actually study, right? That's how we ask questions about things. But there's no way that all these doctors don't know that that's what's happening, that these are correlation studies and not randomized trials. So why are they not protecting us? Why are these regulating agencies letting correlation effectively be causation? Why are they treating it like it's the same when they went to medical school and they know the difference?
Let me get my crystal ball out here. This have to be speculation. Do I want the listeners to have a little context here? Okay. A librarian friend of mine, National Library of Medicine, told me now there are over 250,000 biomedical journals. Medicine is a big business.
It's 19% of our GDP.
And going up, right? I was at JAMA, right? I was mad. I was at one of the biggest medical journals, and I've been at and I've been on review boards for many of them. And I would say, look, we shouldn't be publishing observational trials. Those are hype. I love what you said. Those give us ideas about what we should test, right? Those are what they are for. They shouldn't be in the hands of the public, right? And they shouldn't be published in JAMA because people read it. And people read it and say, by golly, it works. Look at there, you're better. It's statistically significantly different. Well, people don't realize statistics have nothing to do with decision-making, nothing. It is not a decision-making technology. It is a number estimator, right? And I said, let's not publish it. And the editor looked at me and said, well, then we'd only have to publish once a year. And I laughed. Everybody around the table laughed. And I said, well, that's what's wrong with that. I said, let's publish once a year and have everything we publish be worthwhile to the public, right? And they said, well, we need those pages. We need those advertising pages. Jennifer, we got a problem. And that's why my view, I've been trying to change the medical profession for a long time, through education, through bills, through plans. Give you an idea, I was asked to actually give a talk to a bunch of finance people at the Walton's College of Business on how they should invest in healthcare. And my message is that if you're investing in this healthcare, you're behaving immorally and unethically. What you should be doing is investing in a new insurance plan based on evidence and scientific rigor that occurs on a day-to-day basis. And they said, well, we can't, that doesn't make sense, man. We got 20% of our gross national product going to that. It's going to be hard to change it. But I tell you what will change it, an informed public.
Thank you for that. Yes, because
An informed public that says, you know, that's really nice that you allow electroshock therapy for me for having a headache. But quite frankly, I've looked at the evidence. It's not good enough. Have a nice day. Right. And I may be all wet, but you're talking about somebody who's been thinking about this hard for a lot of his life.
Yes.
Trying to make substantive changes for the betterment of people. To make what I wanted to do is be a servant profession, right?
Amen.
And it doesn't make me wonderful. It doesn't make me. I don't get any. I don't get a fast track into heaven. I mean, it's just what I am, right? It just, and I think that's what drives me, and I think that's what should drive the public. Because if we did that, it wouldn't matter what the FDA said. I could care less what the FDA said. Right? I could care less. Give me the data. Show me the data. I could care less what the CDC says. It's not their job. Their job is to give me the data so I can make a choice. Yeah, don't talk to me about evidence people at the National Library of Medicine. Show me the data. I think the National Library of Medicine should be pushing it out to the public everywhere we go, just like a stock market. I would have the stock market medical evidence going within the next 6 months if somebody would give me the chance. And then you'd be seeing what these things were doing, and an informed public will go, whoa, 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 wait a minute. That's where I think the future is. It's not because that's what I do. I don't need tenure. I don't charge for any of my consultation. My days are over, except if I can get this bill passed and keep teaching students and hopefully have a high school curriculum that go viral. You know, everybody's learning this. That'd make me a happy camper. Then we'd see where the chips fall.
Yes. Thank you so much, Bob. I mean, that's our goal at the Medical Wisdom Project too, is an educated public. We're not trying to reform the profession or the trade. It's the public that will make changes, and that's our system of government, and it's a wonderful thing. So
if we think that the doctors and the hospitals and the insurers and the government are going to change this, we're whistling Dixie. We're lost. They're not going to do it. We make too much money off of it. It's a boulder rolling downhill.
So thank you for listening. Dr. Bob, thank you. It was excellent. And as we close the program, let me tell you how you can stay in touch with us. Follow us at Medical Wisdom Project on Instagram, or find us on our website, medicalwisdomproject.com, where you can become a subscriber by simply signing up for free. And this program will also shortly be available to you on our YouTube channel at Medical Wisdom Projects. So in addition, my book called The Patient's Survival Guide is available on Amazon and other places where fine books are sold. Dr. Bob, you also have a book.
I have a book out there also called Your Health, Your Decisions, Working with Your Physician to Be a Knowledge-Powered Patient, 2016, UNC Press, where I tried to get it out into the hands of the public.
All right, buy that book.
I made my students buy it and read it, and that really helped. It gave them a context. And if you want to know more, you can read it.
Say the name one more time, Bob, because we
Yeah, I just want everybody to know that I really don't have a conflict of interest. I think I get 69 cents out of every book, $20 book. But now my students bought it on Amazon for $1.13. The lowest price for my book on Amazon was $1.13.
Okay.
Talk about a humbling experience.
Give our listeners the title one more time before we
Your Health, Your Decisions, working with your doctor to be a knowledge-powered patient, R.A. McNutt, UNC Press 2016. Thank you so much for having me on. I really wish nothing but the best for your project.
Amen, and we'll do it again.
Deal.
Deal.